am I'm going to be talking about trying to make a transition from doing research on intervention development and a lot of efficacy trials to trying to scale the work that I've been doing. And this is actually, it's been a long-term passion project of mine that we've developed health behavior change interventions that work. We've replicated them. We've made them more efficient using most factorial and smart designs. But one thing that always frustrated me is that although I was the co-lead for cancer prevention at Northwestern for 20 years, I was never able to get to the point where the cancer patients, and particularly the survivors who wanted these treatments, could get them. They simply were not available. And that struck me as just really a very bad health practice. And so I wanted to see if I could get these treatments made available. So that's what I'll be talking about. Let's see. Okay. So first, I want to just touch on why is it that we want to use mobile health. I think everybody has already drunk this Kool-Aid, but let me just review it. So in the case of treating health risk behaviors, we want to extend people's access to care. This is a way of even having health resources in your pocket so that they're with you all the time. It's a way to increase people's engagement in managing their health. Often, mobile health tools are used to just provide health education. And one that's very, very important for me as a behavior change person is that it's a tool to support self-regulation of behaviors. One of the things that we know is very effective, it's one of the core elements of behavior change, is self-monitoring. If you're not tracking what you're doing, the odds are about random that it's going to change. So the only way you can change it is by knowing where you are, what your goals are, and trying to close that gap. The other thing that we know is a key determinant of whether somebody will succeed in changing their health behaviors is social support. And that can come either from your peers and your family, or it can come from professionals. In the context that I'm working in cancer survivorship, the clinician plays a really important role. So the support from the clinician matters. And if there's anything we can do to reduce burden and keep costs down, but maintain the communication, that's a critical asset. So with all these good things, what's not to like? Why would we have any trouble getting these kinds of tools adopted in medical care? Well, I have become, I have been going to school in this project. I have had quite an education, learning to take a different perspective than the one that I've usually had. I'm usually over here in this, can you see my cursor? No? Yes? Okay, great. I'm usually over here in the researcher who's developing the tool, what implementation scientists call the thing, because it could be a technology, it could be an intervention that's technology supported. It's a thing, but that's where my investment is. And it is hard for me to see the small text. Is there a way that I can expand this? It may not be. I'm just used to being able to maybe pop out. Okay. Oh, there we go. Okay. I'm used to paying a lot of attention to the design of the protocol, some attention to its cost, and particularly to whether it has an evidence base, because we want evidence-based procedures to be used in healthcare. We don't want sort of fly by the seat of your pants, or it seemed like a good idea at the time. So those are the things that really worry me. But now I'm in a different context where I've developed this tool and I would like it to be taken up by the hospital, and the hospital has gatekeepers. Oops, they are medical personnel. What I'm showing here is a framework that's called CFR, or the Consolidated Framework for Implementation Research, that was developed by Laura Damschroeder, who actually was a participant in this course a number of years back. And she gives a very useful education about the kinds of things that wind up determining whether an innovation like our interventions is going to be taken up in care delivery. She starts by focusing on what she calls the inner setting. To my view, it would often be the outer setting, but she's living from the perspective of a care delivery person who's in the hospital. And the things that are really going to matter there are, oops, sorry, I can't see. I wonder, all right, I will just wing it. So one thing is that the healthcare delivery system has lots of priorities, not just the one that we're working on for our study. They have lots of things to spend their resources on. And they have other stuff that they're trying to get accomplished. This is really, I'm sorry. Shaheen, is there anything I can do to expand this?
You can look in the bottom left in your views and try to expand. So you can, it's
Magnify the
more.
slide for all, maybe?
Do you see that
No,
setting?
I do see that.
And is there another setting that you might see magnify slide only for me?
I see magnify slide for all.
And that's not magnifying for you as well?
It is, well, not fabulously. Let me see this slides in high contrast.
Yeah, I would say try to magnify that to the point, and to everyone who's on right now, if you're looking at the slide, look at the lower left of your screen and click on the three dots that say more actions, and you can use that magnify slide if you need to zoom in.
Perfect. Okay, great. All right. So when we're talking about what will get taken up in a hospital care setting, it matters whether what you're trying to accomplish is aligned with the mission of the place, how important it is relative to other things that they're trying to manage. If COVID came along, health behavior change would probably move way down in the priorities. Incentive systems. Are there financial incentives for doing what we're asking them to do? And then there are issues about the culture. And that wound up being a pretty important one for what I'm trying to do. And the tension for change. I'm working with Northwestern Medicine and particularly the Lurie Cancer Center. And, they do really well. Their cancer center got the top score possible in its last review. So sometimes there's not as much tension for change as I might like there to be when I'm trying to get an innovation introduced. Okay, here we go. Sorry about this. Okay, so let's now go back to what's not to like. Let's talk a little bit about the alignment of priorities and incentives and the culture and this tension for change. What do I mean by that? Well, an odd thing for me at Northwestern was co-leading cancer prevention for 20 years. I would have thought that they're spending a half a position on doing cancer prevention. You'd think that they would be very attuned to the fact that there are risk behaviors that have a real impact on whether somebody gets or has a worsening course of cancer. In fact, 40% of cancers in the U.S. are attributable to modifiable risk factors that you see here in the bar graph. And Smoking, of course, is the big player, but 20% is due to overweight, poor diet, alcohol, and physical inactivity. And yet, for at least the first 10, maybe 15 years that I was there, I was always being asked, well, what does that behavior have to do with cancer? And I was kind of mystified by this. But what I finally came to learn is that in many cancer centers, particularly high prestige ones, and probably at NIH intramural, it's the basic biological sciences that have the most cachet. And so that's where the emphasis and the priority tends to be. And so I had a co-lead who is a cancer biologist, and her view was, look, it's not cancer prevention if you're just treating a risk behavior, because that could be a risk behavior for any chronic disease. It could be diabetes, could be heart disease. So the only way we can say it's cancer prevention is that somebody has to have biological evidence of a cancer risk. Then we take it seriously that it's cancer relevant. So I came to think, okay, they have to have half cancer, and that will be good enough. So what we finally decided to do, and we did it for the study I'll be describing, is we said, all right, cancer survivors, they've obviously got a biological predisposition to cancer. They've had it already. And nobody is going to argue that their health risk behaviors are not relevant, because what we know is that they are relevant. They decrease the efficacy of cancer treatments. They increase the likelihood of a new cancer or a recurrence. They increase the likelihood of cardiometabolic disease. They worsen quality of life, and they really ratchet up cost. So we went with cancer survivors. And this actually wound up explaining a lot for us, because something I had not fully appreciated is that cancer survivorship is actually a fairly recent phenomenon. The first meeting for cancer survivorship happened in Santa Fe in 1986. There were simply not good enough treatments before that to have many survivors. And so you have Patty Gans, who was, I think, the only physician at that meeting, commenting that survival was really all there was. You should just be grateful to be alive. So what that you're having a heart attack because you had radiation to your chest, or you're infertile? At least you're alive. That was our goal at that point. But fortunately, as treatments got better, we began to have many, many more survivors. And they were very effective lobbyers. Institute of Medicine got on board and said, look, quality cancer care is not just treatment of the disease, but it's the promotion of long-term health and quality of life. So we had advocates for us saying, look, these cancer survivors want this health behavior treatment, and they should have it. That's part of good health care. Okay, so now, wrong way. Okay. So now what's happened is that there are guidelines, treatment guidelines for all oncologists, all physicians, that they should be offering health promotion, risk behavior treatment for all cancer survivors. This is a set of NCCN survivorship guidelines for patients that just came out in 2024, but there are parallel ones for physicians. Oops. You might wonder whether there are survivors who have risk behaviors. It seems like maybe they would, once they got the disease, they would get over them. But it isn't really true. About a third of them are not physically active enough. 14% still smoke. About the same proportion as in the population are overweight or obese. And about half have two or three of these risk behaviors. They tend to occur in bundles. So we were very fortunate to be able to get a cancer moonshot grant, a P50. And we were in great company with NYU and Duke and University of Pennsylvania and Memorial Sloan Kettering. And ours was all about introducing this healthy lifestyle program to live well after cancer treatment and making it available through the cancer care delivery system. my multiple PIs on this are, each of us had a piece of the expertise that was needed. So I have done multiple health behavior change. I work with smoking, physical inactivity, obesity, poor quality diet. Brian Heitzman is actually someone I trained who does smoking cessation. Siobhan Phillips, I mentored her Kay. She's a physical activity researcher. And Sophia Garcia works with Dave Sella on patient-reported outcomes, which they have integrated. They've integrated the assessment into the electronic health record. So she was really our sort of EHR, electronic health record wizard. Okay. So this, we had done a lot of work over the years optimizing the technologies that we used for helping people track their behaviors. We started with Palm Pilots. You'll recognize that little yellowish green thing up top. We moved on then to Android and iPhone with more colorful icons. We had one of the earliest accelerometers called a shimmer that was Bluetoothing somebody's physical activity data to the smartphone. Then we moved on to Fitbits. We have Wi-Fi scales, Bluetoothing how the person is doing to their app. We get a little bit fancier iconography, more like Apple. And then we added more behaviors and added some affective sampling in some of the later stuff. What you see consistently in here is two things. One is the behavior change techniques that we're using. These are well-validated behavior change techniques. They work, and they're sort of uniform. You can use them for most bad habits. So setting a goal, self-monitoring to see how you're doing relative to that goal, having decision support, like in this case, you can look up a food to see what its calories and fat are. You're getting feedback because the app is giving you this visual feedback on how you're doing relative to your goal. Sometimes we use incentives, not always. And a very important thing is that there is social support and accountability from a coach. You'll see later that we've tried to see if we could eliminate that because it's the most expensive. And long story short, not so much. We don't do very well when we try to eliminate that. This is what we call our wireless self-regulatory feedback system. So you have, oh, I see this is a headless participant up here. This person is tracking on the app. They're getting lessons on their smartphone. They're wearing a Fitbit. They're using a Wi-Fi scale. And their data are being transmitted to a health promotionist, to the coach. The coach is monitoring what they're sending on this dashboard. And they are giving them they are giving them feedback and social support. Okay, I don't know where. Okay. So those are all different kinds of mobile health technologies that we used in these interventions. And we wanted, most importantly, to have an evidence base that they did something helpful. And we developed that evidence base over a long time. Lots of publications in really nice outlets, including JAMA. And I have to say, my fantasy growing up as a behavioral scientist was that, okay, if I learned how to do interventions that had clinical trials of a quality that could get into top tier medical journals, I would have solved the problem of translation, because then I would be beyond this problem that I don't know if Byron will show this slide, but I'm thanking him in advance. I borrowed it. Too often, our treatments get from the bench where we develop them to the bookshelf where we publish them, but they don't get translated into practice. That's what implementation science is all about. In fact, it takes about 17 years for 14% of research findings to finally get into clinical practice. There's a voltage gap drop. And so this is what we wanted to happen, but the publications didn't do it. That it was not enough. This is a model that I have just discovered, and I'm pretty excited about. It was presented by an Australian group at the last CHI, the User-Centered Design Conference. It's called the Double Diamond Approach. And it starts with user-centered design. Now, most of us who work in mobile health have learned a thing or two about user-centered design. We do a lot of alternating between discovering and defining tools that will work for somebody's needs, their core values, will help them feel empowered. But usually what we're doing in user-centered design is that we're optimizing the relationship of the person and their intrapersonal needs and feelings and values and the technology, which is great for getting engagement with the technology. The problem is it's not enough because things tend to stop there if that's all you're doing. There is a framework called the NAS framework that Tricia Greenhall developed. NAS stands for non-adoption, abandonment, scale-up, spread, and sustainment. And this is where the implementation science enters this model. Basically, in implementation science, what you're trying to do is to get these evidence-based practices to reach their target populations who need them, to be scalable to different contexts, not just the one where you happen to be rolling them out, and to be sustainable over a period of time. We know something. Sorry, did someone ask a question? No. Okay. We know something about the determinants of whether something is going to be taken up. They are things like the value of what the innovation is that you're trying to introduce, the business case for it, how desirable the patients feel that the innovation is, the system feels, what's its efficacy, is it safe above all other things? What are the characteristics of the adopter system? And here we have partly patients. We want acceptability by the patients. And we also have the hospital staff and the leadership of the hospital. And this is a big deal because hospital staff, medical staff are busy and they have prescribed roles. And if you're going to go changing them, it's going to create some pushback. There are also organizational characteristics, like just what are their resources? How overstrapped are they? Do they have a capacity to innovate? Are they ready to make a change? Do they want to? And are you going to do something that's going to interrupt workflow, which really, really is important? I had an experience actually when we were designing this intervention. We met a lot with Dave Sella's team, which has introduced patient-reported outcomes, sort of self-reported symptoms, as part of the standard assessment procedures for the hospital. They collect them multiple times, and they were very pleased with them. Were doing a great research program on them. But as I was starting to develop this program, we discovered there was tremendous pushback, but I didn't understand where it was coming from. Well, it turned out where it was coming from was that the people who had decided to introduce the patient-reported outcomes were researchers and physicians and leadership. The people that hadn't really felt, well, I don't know whether they had not been consulted, but they didn't feel heard, were the operations folks, the nurses. And they felt, look, this is getting in the way of workflow. It's taking our time, and it's not contributing directly to patient care. It's just doing research. So we learned that was really important, that we had to really pay attention to workflow and listen to all the stakeholders. There are wider system issues like the policy and regulatory context, which is going to come up for us. This became a big issue. There are professional guidelines, which are helping us in this case because you expect the healthcare professionals to be doing these interventions. And there are, of course, issues of reimbursement, which also wind up being really important for us because the medical staff is under a lot of pressure to generate revenue and to keep themselves supported. So they have to pay attention to that. And the last thing is there scope to adapt and evolve over time? Because that will happen, and you need a model that allows it to happen. Okay. So another thing that can be a problem is the structural alignment. I already mentioned workflow. There are the roles of the care team, and how do they communicate? Because that's vital. They're trying to keep people alive, keep them well. They have to be able to communicate, and you don't want to do anything to get in the way of that. So we started by doing some qualitative interviews with physicians at Northwestern Cancer Center. It's a small sample, but it was a chance to learn some things. We started with 30 surgical or medical oncologists. There were 50% of each. 30 general practitioners in family medicine or internal medicine, and 31 specialists who were addressing the cancers that we were mostly working with. Breast cancer, so we were working with OB-GYNs. Prostate cancer, we were working with urology. Melanoma, we were working with dermatology. 63% of them were female, vast majority white, vast majority non-Hispanic. It's an issue at Northwestern. There is not the greatest representation of minorities, either in terms of the patient population or the staff. There is good distribution of ages. Between 31 and 65, there were grouped them into 3 age categories, and there was fairly equal distribution. So that was good. Okay. So we asked, for what percent of your patients who are cancer survivors do you recommend ways of improving their lifestyle, like smoking cessation, weight loss, or increasing physical activity? And what we found was that the tall bar here is the general practitioners. They almost always, like 90% of the time, recommend lifestyle changes. The oncologists, sorry, yeah, 90% of the time they recommend, the general practitioners recommend lifestyle changes. The oncologists don't recommend them about 70% of the time. Specialists are even worse. They don't recommend them 90% of the time. And so that was not so good. So we've got 3/4 of the oncologists saying they never give lifestyle recommendations. Okay. We got more direct. We said, well, maybe they're thinking it's a trivial cosmetic concern. So we asked, if an overweight cancer survivor asked you how they could become healthier by losing weight, what would you do? Select one of these answers. The general practitioners got right down to work. They said, look, we'll agree on a healthy weight loss goal, and we'll advise the patient to use an app or a commercial program to track their calorie intake. Go for it. That's not so much what the oncologists or the specialists did. What the oncologists mostly did was to say that since their cancer is the most important issue, I would tell them that staying in remission is the priority, which was really eye-opening. They seemed to think that there was a kind of a zero-sum game, that a person only had so much capacity, and if they were getting distracted by trying to have a healthy lifestyle, they might not take care of preventing their cancer from coming back. That was at least better than the specialists, who mostly said, I tell the patients that I don't discuss matters that are not in my area. So we clearly had an issue with uptake. We took it further and interviewed them. What we were able to do was to present them with the survey data and show them that their peers were not raising these issues of lifestyle. But at least we could show them the average. So we were not showing them their own responses, and this let them try to explain what their peers were doing. They said some very interesting things. One thing they talked about was tunnel vision, which makes a lot of sense. They said, look, we're so focused on the life or death aspects of cancer that everything else falls through the cracks. Well, I shouldn't say it falls through the cracks, but it gets ignored. That's going to require a different way of thinking for oncologists, meaning, you know what? I also got to pay attention to that kind of stuff. Before, I could just be like, well, we don't have to worry about it right now because I'm just trying to keep you alive, which is it makes a whole lot of sense. And then the other big issue that was raised a lot is production pressure, especially in this academic environment where there's stress to produce, stress to generate revenue, see as many patients, increase access, increase billing. You can't have half-hour conversations with people about weight loss. We don't have a sit down in the conference room and talk about 15 to 20 minutes about this. That's another 2 patients. Very real concerns. So we sat down and thought about this. One of the things that became very clear is that the hospital and indeed billing requirements, third-party payer requirements, want the medical team to deliver this kind of treatment. But MDs and advanced practice professionals are not specifically trained in behavior change. They're really busy and they are well paid. And the reimbursement for behavior change is not cost effective for them. It's not really worth their time. So, what we did was we developed a new role. This is an implementation strategy. We came up with a bachelor level, clinically supervised health promotionist who is a coach. This is sort of like a community health worker, and they had the advantage that not only were they trained in behavior change and they were supervised by licensed clinical health psychologists, but they were also younger than a lot of the clinicians and they're digital natives. So they were able to help with something that can be a problem, particularly with older patients. They gave sort of warm tech support that was efficacy building for the patients. Second thing was a way that behavioral folks participate in creating a barrier. As a health behavior change person, I know that most of us, most clinical health psychologists, specialize in treating one risk behavior. It's pretty unusual to have an odd duck like me that can treat smoking, obesity, and physical inactivity. Most people specialize in one. Well, just imagine the scaling of that. It means that in a hospital, you have to have 3 full-time experts just to treat those 3 behaviors. It really doesn't make any sense. It's just not it's not logical. And so what we had to do was to we had to develop a unified treatment protocol where basically the same mechanisms were used to treat each of the behaviors, and all of the health promotionists are cross-trained. We also worked outside of the healthcare setting. We did telehealth to make it easier for patients to access this care and also to ease workflow burden. One of the things that had happened in prior studies is that when coaches would go up to try to offer treatment in person, there was no place for them to sit. They would get in the way. It would be a burden. So we used telehealth and we had the coaches off-site so they weren't in the way. The last thing that we tackled is that most of our treatments, our behavioral treatments, are quite intensive and expensive. They're burdensome. And this, it's understandable. When we were developing this field, it was pretty rare that we got to do a randomized clinical trial. And so by all means, if we did a clinical trial of a behavioral intervention, we wanted it to work. And so what we would tend to do is to throw everything but the kitchen sink into it. So that bumped us up against the business case, another thing not to like. The burden of these treatments, their costs, their, in some ways, inefficiency. And I encountered this when I first went to a medical school. Now, in in our world, the diabetes prevention program is the holy grail of behavioral interventions. It was an intensive lifestyle weight loss intervention for people with prediabetes, and then it was replicated in Look Ahead for people with diabetes. And what it showed was greater weight loss with the lifestyle treatment than with metformin. And also a greater delay in the conversion from prediabetes to diabetes. Now, those are real biological outcomes. But when I talked to my colleagues, and I would say, well, have you ever heard of the diabetes prevention program? They would think for a while, and they would tend to say, oh, yeah, that's the one that showed that metformin delays the conversion from prediabetes to diabetes. And I was always mystified by this until I started looking at these data. So what you see in the graph on the left is that the solid blue lines show that a year of treatment for lifestyle intervention, which was done individually, was about $1,800. We could get that cost down. If we did group treatment, we could get down to about 800, but it was still more expensive than metformin. And of course, you can't stop doing it. You have to maintain. And so look at how the cost ratchets up over time. And I think my physician colleagues just looked at this and figured, oh, come on, this is just not scalable. Yeah, you get this great 7% sustained weight loss and metabolic improvement, but it's 16 to 36 sessions. It's in person, they're hour-long sessions, and it costs a fortune. So that's what our classic treatment package approach gave us. But when we looked at it, we said, okay, all right, we'll try to scale it down. But we had this kitchen sink of components, and we didn't really know which ones were doing the work, which ones were worth their salt. We had 24 to 36 treatment sessions. The treatment was in person. They were 60-minute sessions, $1,800 per year. The interventionists were health professional counselors, and they were using meal replacement and Look Ahead. They gave people all of their food. So obviously it costs a lot, but what can we take out without the whole thing toppling over? This is what, oops, this is what most methods, the multi-phase optimization strategy is all about. And Billy will introduce one of the designs, the SMART design, later in the talk. But I'm introducing this here because I think that what we have tended to do when we talk about implementation of mobile technologies is we get as far as optimizing the user-centered design, and then we go to try to scale it. But I think often we've got other work to do along the way, and it involves optimizing our interventions to make them more efficient and effective. And there are a couple of ways to do that. I won't go into great depth on this, but the factorial design is one where you're doing a screening experiment, turning on and off components to see what has the most impact at what cost. It's giving you an evidence-based practice. And then the SMART design is one where you're trying to do stepped care because you're trying to reduce costs by giving people what they need, not more, not less. And so you start them with a less resource intensive treatment. You see if they're doing okay. And only if they're not do you step up and invest more resources in them. So these are results from a factorial trial that we did of basically a dismantled DPP. And what you can see is we turned on and off these different components. We had 12 versus 24 calls. We gave meal replacement recommendations or not, a bunch of things like this. And we had a criterion for optimizing, which said, we want the intervention that gives us the most weight loss for the least cost. It has to cost less than $500. And what you see on the top is it was this top intervention where it had a couple of sort of interesting components. We gave the primary care doc a report. We trained their buddies to be supportive, and it cost less than $500. But if you're in a less resource rich environment, you might use this one at the bottom that cost about $100 less. It gives you less, it gives you a kilo less weight loss, but it's still pretty darn good. Now, the smart design that we did said, okay, now let's see if we can eliminate the most resource intensive component, the human coach. So we started people off with either their app plus the coach, or with just the app alone. And long story short was, we found we could not get rid of the coach because starting people without the coach gave them a worse outcome. It was unacceptably worse weight loss. It was not non-inferior. So we're not ready with our mobile technology yet to give up the coach. I want to kind of orient us here in this research pipeline, which is how we've usually done research translation. So we developed some kind of a treatment. We started with efficacy studies where you have perfect conditions. Then we went to effectiveness studies where we loosen things. We take patients with comorbidities. We have the care delivery staff do the intervention. And then we try to get them taken up into practice, which is what implementation research is all about, and what Byron will talk to you more about. Good thing is we've now recognized that we have some hybrid designs that are sort of straggling between developing the efficacy and effectiveness of a treatment and looking at implementation. But I suggest that our pipeline should start sooner and should incorporate the redevelopment or optimization of treatments as well. That just like we did, we couldn't just scale our pretty nifty mobile health technology assisted treatments because they were too burdensome. We had to make them leaner and meaner. We had to answer questions for the hospital administrator, like, could we do this with only technology? And we had to have the evidence that no, we couldn't, and it wasn't cost effective. So I think this is a longer research pipeline than maybe we've thought. Tell you a little bit about the study that we're doing, our Stellar Center. What it aims to do is to integrate telehealth cancer behavioral risk factor assessment and treatment into care processes across 11 Northwestern hospitals and evaluate the impact of it on REACH, which is our primary outcome. That's getting the treatment to the patients who need it, on health outcomes, which is the behavior change outcomes, and healthcare costs. This is a pragmatic trial. We're comparing our treatment to enhanced usual care by doing a 2-arm parallel group trial. Next time I will practice this technology before we do this, Vivek. There we go. So here is this is the distribution of our care delivery system, our cancer care delivery. We have 11 hospitals that are located across 5 regions. They see a lot of cancer patients, almost 70,000 in a single year. There are 52 clinics, and there's an electronic infrastructure that makes this feasible. They're all on a single electronic health record, Epic. They use the Teams telehealth platform, and there's a daily repository of all the clinical and research data that is collected daily, and it's updated daily. And it's important. This will become important when we talk about institutional firewalls. It is anonymized in an enterprise data warehouse that's kept at the university. And we have champions for our intervention in each region. Okay, here's the design, the trial design. We are looking for people that have either physical inactivity, overweight or obesity, or cigarette smoking. Initially, we were requiring them to have more than one. We will take any one because our interventionists can treat any of them. We enroll them and screen them, and we randomize them to what we were originally calling Stellar. That was our active intervention, or our control intervention was enhanced usual care. The Stellar intervention involves this daily self-monitoring with the app. It involves 16 10 to 15-minute health promotion telehealth sessions, mostly by phone, and it involves giving reports to the clinical team. The enhanced usual care gets the National Comprehensive Cancer Network health promotion guidelines. They get curated health promotion materials about the behaviors that they're trying to change, and they get tailored community resources. Something that we learned very quickly when we presented this to the clinicians is that they did not feel that this was a trial that was at equipoise. They said, look, I really have reservations about referring or supporting a treatment where the odds are 50% that somebody's going to get nothing. Well, they weren't getting nothing, but it seemed like it. And we needed to carefully reframe and make sure that people were getting credible treatment components. What we now call these treatments are our facilitated one and our self-guided one, because some people think the autonomy of doing this on your own is an important benefit. Okay, again, what not to like. Here we run into some alignment issues between institutional regulatory and supervisory content. It becomes an issue for staff appointments, for supervisors, electronic health record access, the data transfer with the app, electronic health record programming, the priority of how we get communication with the clinical team. And let me show you in this diagram what I mean. Something I had not fully appreciated until we got into this, but many others of you may encounter this, is that the hospital, although it's a Northwestern hospital, it's actually a completely separate corporation than the university. There is a, hard to see, but a firewall, a firewall between them. And so what we had before was a system where everything was done outside of the hospital. We were interacting with the cancer survivor or any other patient, and the data were going to the health promotionist, who was also outside the hospital and available by telehealth. But now we were trying to integrate with the care delivery team. And so we needed to be in communication with them to let them know how the patient was doing. And what we came up against was, this was very complicated because the patients the health promotionists were not covered by the institution's insurance. So what we decided we would do was to have them quit their university research assistant positions and become hired by the hospital. But as often happens when you're managing a group of people, they really didn't want to do this because their health education benefits through the university were much better than through the hospital, because the university offers courses, and many of them take these jobs because they're earning a degree. So we paid a price. We could not fully access the electronic health record. The IT, the EHR builds that we needed kept getting deprioritized because, very rightly so, clinical needs take priority over research needs. So there were some issues. Oh dear. I don't know if you're going to be able to see this. Long and the short of this is that another thing that we paid a price about is that the hospital could not integrate data from our app. We intended to have the data from our app port directly into the electronic health record, which would package it as feedback for the provider. They couldn't do that, couldn't cross the firewall. It turned out actually to be somewhat fortunate because what the clinicians preferred actually was not, they didn't want the data from the Fitbits or the Wi-Fi scale, didn't want the direct data. They were in some ways afraid of liability, that if they had something and they hadn't seen it and they were expected to act on it, this could not work well for them. So that was one issue. We gave them infographics that gave them progressive, sort of historic data on how people were doing. They didn't like that because it was too difficult to process in the time of a very brief visit. So what we settled on was a very short message that we had to put in through the provider's in-basket message. So this is sort of, it's like an email that goes to the electronic health record, but it's not actually in it. And what we did was, in very short, plain English, we told them, okay, this is the patient's 3 goals. They're meeting this one, and this is by how much. They're meeting that one, and this is by how much. They're not meeting this one, and they're not meeting that one. And then it gave a crib sheet, very quick, pithy messages that the provider could give to say, to congratulate them on what they're doing well on, and to encourage them on the other things. So it engaged the provider, it made them look good. They didn't have to be trained on health behavior change, but they could participate, and their support is vital. So that was pretty important. Okay. Other things that came up, and these were surprising to us. When we were framing what it is that we were trying to do, we had multiple advisory boards, patient advisory board, the internal advisory board, external policy advisors, and so forth. Our clinical advisory board told us in no uncertain terms they did not like the terminology about risk behavior or changing unhealthful behaviors. They really didn't like it. They said it hinted at blame, that they heightened their own cancer susceptibility by making poor lifestyle choices. That's pretty hard to hear. So we adapted. We took their advice and we used positive language that emphasizes the survivor's motivation to regain control over their health after cancer. We call the intervention health promotion rather than risk behavior change. And we script all of our patient-facing portions of the intervention materials, like the lessons, the scripts that the coach uses. We scripted them in that very positive way. However, because life is never simple, the oncologists didn't like that language. They liked the risk behavior terminology because they felt that it captured their attention better and it motivated them to act to promote the patient's behavior change. In the very appropriate words of one oncologist, look, hearing risk behaviors means I need to do something. Health promotion means the psychologist needs to do something. So how we adapted is that our provider-facing materials use risk behavior terminology, and our just coming back to this, I want to again emphasize something that excites me about how the field has evolved is that we are really no longer working, I don't think, in siloed linear progression. Used to be, we did the basic mechanistic research studies, then we did a very clean efficacy study. If that worked and gave us big effects, then we went on to effectiveness. And only then did we worry about implementation, about getting it taken up and used, if we worried about that ever. We're now toggling back and forth much more. And I'm suggesting that we may need to do even a little bit more of it to remember that sometimes we need to redevelop an intervention before we even get to an efficacy study. We need to go back to optimization. But I think this is real progress, that we're not sort of so linear siloed that then we toss something over transport to the people that are doing the next stage in the research. So I will just stop by saying I think that mobile health, the field, is progressing very nicely. It's going through a kind of a social technological dialectic between user-centered design, which is really valuable and important, but mostly addressing intrapersonal factors, intervention optimization, which is dealing with the thing and making it leaner and meaner and more scalable and more efficient, and implementation science, which is where the rubber meets the road, saying, look, let's get these things to the populations that need them and get them maintained so that they'll stay around for the next generation of folks. There are translational barriers, for sure, but we can go to school when we do this kind of research, because I think informed scientists and care delivery settings learn to understand each other and find workarounds. This is really classic team science. We don't know what we don't know when we start out. We have to learn it. And I would suggest that rather than thinking about this as a linear pipeline, that we think of it as the iterative use of a translational toolbox, and that may help us to be pulling the tools and techniques that we need rather than sort of trying to stay within our little siloed box. So that's it, and thank you for your attention.
Bonnie, thank you. Again, wonderful wisdom from the lived experience. Let me open it up to the scholars. They may have questions. Feel free to unmute yourself, and we'll have 5 minutes of Bonnie's wisdom. You'll have more access to her during the institute. But please, any reactions? See a lot of clapping hands.
I'm gonna stop present. Oops. So
That's
maybe
fine.
I can.
Well,
Yeah, hi, Bonnie.
Then I can see people. That's nice.
Yeah, hi, Bonnie. It's Jazz. Good to
Hey,
see you
Jazz.
again. You know, that was, first of all, that was a great talk. It's really fantastic.
Thank you.
You know, outstanding work. Um, you talked about it a little bit, but just can you just comment on, especially because you've done a lot of work in obesity, and GLP-1s are now over $100 billion market.
Yeah.
And in the smoking world, cytosine is going to be a new approved drug. I'm part of a startup company that's working on an inhaled nicotine device, and people are like not smoking anymore; they're vaping. You know, what's your thinking on how to integrate this with the profound expansion of pharmacotherapy and
Yeah.
progress made in that area?
Well, this is the $1 million question. I think we've done pretty well in smoking cessation. We actually, in the treatment in the multiple behavior change treatment that I've described, we actually do integrate pharmacotherapy. This was another thing that made it very hard. We were stopped in our tracks initially by the university, which said, you're prescribing drugs to people. We're not. We're psychologists. We coach. We don't prescribe drugs, but we work with oncologists who prescribe the drugs. So that's how we're supposed to work as a team. But again, it can be hard for people to divide those roles, understand them. In the case of Ozempic and the GLP-1s for obesity, there is so obviously a need to put these things together because we have very real issues like that. So many people have such bad side effects that they have to come off the drugs, or they encounter supply chain issues, or their insurance won't continue to cover it, or on and on. And what happens is that when they come off the drug, they regain everything that they had lost. So we have very interesting problems to tackle there. One of which I think is the fact that when you're on a drug, you're not experiencing some of the craving and other cues that are what's getting you into trouble when you're walking around in your regular environment. And we don't have a way to mimic that, but those are some of the things that people need to learn to self-regulate. So obviously, we need to figure out how to put these things together. We don't know yet. We need a science in that arena, and it's going to be pretty exciting to see it develop.
We'll take one more question if there is. And
Hi, Dr. Spring.
Could
Thank you so much
ask
for
a
your.
question?
Oh,
Please go ahead, Ryan.
oh, thank you. Just a quick question about the JAMA article that you shared. Thank you so much for presenting your work. It seems like you suggest toward the end of the article that AI might potentially help address the null finding. In this case, I'm curious if you could comment a little bit more on are there any particular features of the AI that you think might help achieve non-inferiority? Just curious about a potential follow-up study and how you're thinking this through.
This is just so interesting. I think I just was just reading something, I forget where, about AI and empathy. Most mobile technologies don't work on their own. They work when there is a human wraparound. There are some exceptions to that. Some mental health programs, maybe some substance use ones, or the ones that are medication only. They can, those are okay standing alone, but most mobile health technologies just, they don't work without a person. You need somebody who's, and we don't know the fully the magic ingredients. We know that they're supportive. We know that they hold people accountable. We know that we have movies like Her that suggest that somebody that they can substitute for a person, but we don't know what the secret sauce is that they're doing. I think we will get there, but we're not there yet. And I think it's going to take a lot of large language modeling and predictive modeling to figure out just what is doing the work there. If you have thoughts, I'd be very interested.